Excellent. Welcome everybody to those who are participating in our second SAASM webinar for 2024. Just a couple of issues to start with. We will be recording this meeting to produce transcripts for people if that's what they would like. So if anyone is concerned about that, then let us know. Hopefully people can see my screen that I'm sharing, and I welcome you all tonight to the SAASM webinar, which is entitled Learning from Deaf, the Benefits of Clinical Quality Registries. I'd like to start by acknowledging the traditional owners on the various lands on which we are meeting on this online meeting, and I recognise their leaders past, present and emerging. Tonight's webinar is going to be focused really on the quality of healthcare audits, and in particular how we can identify and use information contained in perioperative audits such as SAASM and SAASM. I think it's an important and timely issue because in many ways we've collected a lot of data, but only really scratched the surface of many lessons that we have within our audits. We're very privileged tonight to have two speakers that are clear leaders in their respective fields, and you also have me presenting. I would like to welcome and thank on behalf of SAASM Michael Gorton and Michael Cusack for making the time to participate in our webinar. And up front, I'd like to thank the SAASM staff for their work in putting this evening together. So in very simple terms, what's going to happen tonight is that I'm going to start and go through the information and data that SAASM currently makes available to our stakeholders and the feedback we give. Then Michael Gorton is going to tell us if we've broken any laws, and Michael Cusack is going to then tell us what he would really like to hear from us. And so the plan's to run through all three presentations and then have a period for questions and feedbacks for our speakers. So if everybody is ready, I'll start with my presentation. I thought as host, SAASM should probably go first and lay their cards out on the table. So I'm going to talk about learning from dying. If you ask me to give a talk, you're always going to get a little bit of history, and this is Florence Nightingale. So she's known essentially as the lady with the lamp, but she's probably better known as the lady with the ledger book, because in her time in British hospitals, British Army hospitals during the Crimean War, she was well known for her collection of data of outcomes. And it's said that with that data, protocols for nursing and surgical care were changed and the mortality dropped from 40% a year down to 2%. Now, interestingly, Florence Nightingale in her personal journals actually made the comment and the reflection that she thought that the very fact that someone was recording the data and taking an interest and writing it down was probably more impact upon improving care than actually any specific plans or treatments. And I think that's a telling observation that's probably just as true of our audits as well. The other person I want to introduce who is sort of really considered to be the pioneer of perioperative audit, and this is a mid-19th century surgeon from Boston. This is Ernest Codman. He was an orthopedic surgeon. He worked at Massachusetts General Hospital, and he had the idea of what he called the end results. And he went around the hospital with a series of cards onto which he wrote the details, outcomes, and the success of each operation that was done for each surgeon. And Codman and his little cards were so popular that he was actually kicked out of the Massachusetts General Hospital and had to set up his own private hospital. But over time, things were forgiven, and he's now become very much the symbol in American surgical circles, at least, of good surgical audit. And this brings us to SAASM. So SAASM, of which I'm the clinical director, is a part of a wider Australian-New Zealand audit of surgical mortality. In terms of our local background, we were established in 2007. I think we were probably the second state underway after Western Australia. It's now part of a binational process. It's a joint project with RACS and SA Health. It has formal contracts and deliverable KPIs. And I'm very pleased that in South Australia we have got really all the LHNs, both metro and rural and regional, participating. We have all private hospitals, and we have the obstetrician and gynecologists involved. And as I seem to explain to colleagues all the time, it looks at all deaths admitted under a surgeon, whether having a procedure or not, or a death under after a procedure in someone not admitted under surgery. One of the things that we have identified for the future is how much procedural work is undertaken by interventional radiologists, cardiologists, and gastroenterologists. And I guess on my wish list would be to be able to get these groups also into our audit. And I think it's probably, I was involved as chair of the College of Surgeons locally in 2007, and it's worth remembering that at that time frame, the original goal of the audit was really to be a monitoring process to look for rogue surgical practices or rogue surgeons. This was a couple of years after the Bundaberg issues with rogue surgeons, and I think the whole idea was to check for outlying practices, but as we'll discuss, we've become a lot further from that. Most people here would be familiar with what we do. Essentially, we use a potential two-stage assessment process to look at all notified deaths. Based on the response, we ask for a response from the treating surgeons, and we make a decision that a case has been managed appropriately. We may decide that there are some areas for improvement identified, and we, in some occasions, will undertake a full case note review to essentially find the same things. And the other closing of the loop is feedback to the treating surgeon. One of the things that has been something really important has been the timeliness of the data and the speed with which we can complete this process. At the moment, we're about to review our processes to try and streamline them and see if we can sign off more standard cases in a much quicker time frame, and that will also allow us to use our precious resource of assessors for more specific and complex cases. One of the keys to kicking off this process and keeping things rolling along is to get notification of the deaths so we can identify to surgeons that we would like their response. Once things get too delayed, it becomes harder and harder to get engagement with our surgeons. And you can see that over time we have had a very good relationship with our hospitals and networks, and we're getting down our time for SAASM to be notified of a death over the past few years. And of course, COVID is the aberration, but it looks now we're back on track to getting things down to a week or a few days. Over that time, in the last 5 years, the time for us to complete the case assessment from notification has decreased across the audit, both nationally and in South Australia. So even despite COVID, we've managed to make improvements, and this is one of the real issues that we're looking at in our RACS perioperative audits going forward. The feedback is the other thing that is key, because without feedback we don't achieve anything. We do produce quite formal data driven annual reports on both a national and state level. Individual surgical reporting has just been updated, and I think that's a very powerful tool where a surgeon can privately reflect upon their feedback. I think it's very difficult to confront surgeons in public forums like morbidity and mortality meetings and to avoid an understandable human reaction to push back, whereas I think really changing practice involves careful and thoughtful reflection. We're lucky enough to have steering committees that both guide the way in which we run SAASM, and we also give feedback to stakeholders through those committees. Our case note booklets and our case note publications are popular. We spend a great deal of time de-identifying these cases so that they can go out to the surgical community, and I certainly know that surgeons spend a lot of time trying to re-identify the cases once we have done that and they're reading them. We're heavily involved with webinars and seminars such as this. We undertake this twice a year through most of our states. And the things I want to talk about in terms of what I think is quite exciting is the LHN meetings which we've started. We've increased recently away from just the annual meetings, which essentially are going through a list of complications, and we're trying to have informal meetings where we can look at and drill down into the data, and I'm going to show some of the things that we talk about. And I also think that the publications coming from our audits is extremely important resource for surgeons. When we look at the annual report, there's a lot of demographics, a lot of them about patients and technical issues. There's a lot of counting. But this really this is from our most recent annual audit across a national audit paper, and you can see one of the big issues facing anyone that's interested in surgical mortality is that across all of our surgical specialties, we now have an extremely elderly population where the key population group for most specialties now is pushing well across 80, and for something like orthopedic surgery with its fractured neck of femurs, people in that category, 80 is a young patient. It's also, when we do look at the demographics, it's worth remembering that comorbidity averages about 3 or 4 in most of our patients. Nearly everybody, the vast majority of people in our surgical audits are emergency presentations. Elective surgery is thankfully very rarely associated with mortality, but these are the comorbidities. And when you start to look at age and cardiovascular disease, malignancy, obesity, you start to see that in the time frame of the short day or two that you might have to optimize these people, there's very little you can do to make them better surgical candidates. And the compromise that surgeons are making in their care because of the comorbidity of patients, operations have to be varied and the like, is considerable and present in most cases. So the audit is all about finding clinical management issues. We have 3 levels: a consideration, which is essentially where it could be argued that something could have been done better. A concern is where it could be argued that something should have been done better. And an adverse event, which is pretty rare, but usually a specific technical issue or failure. We try and put some impact upon what that had on death, and we look at preventability as well, although these are quite hard sometimes, I think, for assessors to look at. So we look at our clinical management distribution across SAASM, And you can see that the majority of cases are considerations, and I don't necessarily think that these are of a lesser importance. I think that there are a great deal of lessers in considerations, of course, of what was the alternative. And I also think that it's important to realize that whilst we're talking about patients who have died, this is a biopsy of our health system, and the areas of consideration, concern, and adverse event will be occurring in patients who die, which we look at here, but also those who have complications, prolonged length of stay, reduction in quality of life, and overall just a bad experience with the health system. So I've been spending quite a bit of time having telemeetings with executives, really looking at some quite drilled down data. So I just want to talk a little bit about that. One of the things that we have been talking about, and the way we think about the data, is rather than looking at great spreadsheets of tables of numbers, we look at the number of case management issues that have been identified over the number of cases closed. So, for example, in SAASM this year, we're running at 0.17, and overall in our national data, we're sitting at 0.15. So this gives us a number that we can start to compare more simply, and we can also start to show the way in which the graphs and things that we use to show it. So this is the CMI data. This is the CMI ratios over the last couple of years, and you can see that over time the actual number seems to be fairly stable both nationally and in our state. Now you might look across at the end here and say, what's been happening in the last 6 months? Something's going on, and indeed that's the advantage of looking at that problem. The issue here, of course, when you look into it, is that nationally not many cases have been closed compared to the last 6 months period. So there's obviously a large number of cases in states that will be closed, and I suspect that gap will settle, but that's something for us to watch over the next 6 months or so. A few things sort of pop out that are interesting. We all think of emergency patients entering our healthcare system and needing urgent operation. So consistently, both nationally and in South Australia, the time to initial operation in this state is over 4 days. So there is time to plan and to think of strategy and how we're going to manage things for most patients in our audit. And likewise, patients who, this is length of stay, which is effectively time to death, you can see that across the both audits, this is measured in weeks. And so patients are not succumbing rapidly, and the things that we do in those first few days really sometimes put in motion a process that is very difficult and unfortunately quite slow. This is a slide that's worth trying to squint at a little bit, because what this shows is a little bit of information about length of stay and time to operation on a specialty basis. I'm not too worried about length of stay, but I think time to operation is interesting. So if we look, for example, at neurosurgery, which is green, neurosurgery needs access to emergency operating theatres within hours of the presentation of the patient. Vascular is interesting because there's a bimodal distribution. There are cases here that, similar to neurosurgery, need very rapid access, but they also have some slower operations out here that need access within a week or two, and they're obviously for more chronic leg ischemias, for example, and ulcer management. General surgery needs access to theatres within a day or two, but not necessarily within hours. And the orthopedic patients with their NOFs, they really need probably to get access in 30 hours or so. So if you're thinking about how you're going to set up your operating theatres and how you're going to manage it, there's just some data in SAASM about how one might staff and what sort of theatre equipment you would have available. Transfers have come up through the national audit, and particularly with our health system in South Australia is a very important case. We need to transfer a lot of our cases to our very centralised teaching hospitals. And you can see here that if we look at neurosurgery, I've just said that those patients need to have access to theatre within a few hours, yet nearly 50% of them are starting from another location from the hospital at which they're having surgery. So this also indicates where the stresses are going to be on our health system. One of the things that concerns a lot of people is the futility of transfer. In other words, a patient coming from a remote or regional location arriving, and the decision is made not to do any active intervention, and the transfer is considered to be wasted and the patient could have been palliated locally. One of the ways we can sort of look at this is look at those patients who had a length of stay, time to death in under 2 days, and we can see that the transferred and the non-transferred patients are at the moment about the same. So probably what we would see if there were lots of country patients being transferred in but dying rapidly without significant intervention is we'd see a change in that ratio. So this is a way in which we can monitor some of the issues of how we're performing. And this is probably my most interesting graph I've been showing people. If we look at the top line, this is the clinical management issues in South Australian patients who are transferred. And this is compared to this line here, which is the South Australian patients who are not transferred. And both in the national data, which is shown here, and in South Australia, where the problem is worse, there is significantly more clinical management issues identified in those patients who have to be transferred between hospitals. And this reflects patient complexity, issues with communication, and almost certainly an element of delay. But for South Australia, we need to probably make sure we're getting our transfers right. And if we actually drill that down a little bit more and look at transfers in South Australia, it's even worse to be transferred between two metropolitan hospitals because of the complexity of care and specialised treatment than to come from country. Now, at the moment, in terms of publications from our audits, we have over 70 peer-reviewed and independently published publications. 2020, when not much operating was going on, was our bumper year for publications. And pleasingly, when we look at what some of the things that have been published is an independent external validity of our data collection. We've been able to demonstrate that the mortality audit is likely to improve clinical outcomes. We've shown that rural surgery is not inherently unsafer than metropolitan surgery. But when you're talking about transfers, which does affect a lot of rural patients, that's where one of the concerns remains. So finally, I guess originally the audit, SAASM was set up to be the canary in the coal mine. It was to look for rogue surgeons and rogue surgical practice. But in fact, we have a lot more information and we can do a lot of things with that information going forward. And I think the future is that we'll remain monitoring the very basic levels of care, but we also might be able to inform some more sophisticated outcomes from our health system. Thank you. So I'd like to introduce our next speaker. It's Michael Gorton AM. Michael is a principal with Russell Kennedy Lawyers. He has a background in commercial law with a focus on healthcare. He's got a long history of involvement with the College of Surgeons. And tonight he's going to address the legal aspects of audit programs such as SAASM and SAASM. So Michael, I will operate your slides and I welcome you to the webinar.
Thanks, David. Happy to be here. And we can probably get past the first two slides as merely introductory. And so the first slide is the issues, the next one, the issues slide. Many years ago now, when we were even just thinking about the audit of surgical mortality, one of the first issues that came up was confidentiality. So we recognised the great public benefit involved in the audit. I'm not sure then we recognised, in fact, how far it could go and what it could tell us in the future. And so some of the use of the data now being made is, I suspect, more sophisticated than we even thought at the start. But it was, at the time, you may recall that we had an outburst of litigation against doctors. We had expensive cases being launched, group claims being launched, and it was argued by health ministers and ultimately governments that there should be greater protection for doctors generally, not just surgeons, but as one of the ways to convince governments that rogue surgeons or poor practice would not be acceptable, the audit of surgical mortality was one of the ways in which we could demonstrate that the college and therefore the surgery more generally would be dealing with the risks of surgery more significantly. So strong public benefit for what has been done. We wanted to preserve the confidentiality of the doctor. Of course, doctors can always give consent to being identified and recognised. More importantly, there's the confidentiality of the patient. And so we have ways in which the patients can either consent formally as part of a consent form or a patient form as they enter a hospital, or where we're doing research getting ethics approval. And in cases where we're not using identifying information, we can get ethics approval without having to get patient consent for that type of research. But of course, doctors' involvement in a scheme like this back in those days was very fearful. People were worried about being identified, people were worried about being blamed, and people were worried about being sued for poor practice that may be identified through the audit. And so, you know, that sort of information would ordinarily be possibly accessed by way of court subpoena in litigation, whether the doctor wanted to give up the information or not. Similarly, patient information can be accessed through various health records legislation and patient consent. So the audit of surgical mortality was set up particularly as part of a scheme under Commonwealth legislation called qualified privilege, which is the next slide. Thanks, David. So the qualified privilege scheme was established by legislation by the Commonwealth. You needed to apply and register, provide all the details of how the scheme would operate, and provide a demonstration of public benefit so that this legislation could act to therefore restrict access to identifying information. At around the same time, some states legislated for similar reasons. Some states already had some old legislation which covered M&M committees so that there could be freedom to speak in M&M committee meetings about matters without that information having to be divulged publicly, and no writ or legal process could get the information that was in the M&M committee, a very old rudimentary scheme. So the Commonwealth scheme was the best one for the college. It's used for the ASNIPS program and the SAASM program. It provides for statutory confidentiality of all identifying information, and it cannot be accessed by way of any subpoena or legal process. So clever lawyers, we would say the plaintiff lawyers, who are very good at issuing writs all around the place, trying to get as much information as they can. None of those writs apply to information held within the schemes which have been registered for qualified privilege. So the SAASM program is registered. Over the years, there have been a handful of attempts to seek information from the scheme. which we have simply resisted and provided them with a copy of the registration of the scheme issued by the Commonwealth, and that usually sends lawyers and other organisations on their way, and there therefore has been no successful attempt to obtain information out of ANZASM. It's a closed area. So it has promoted, we know, sharing trends of information within the scheme. It has identified new issues along the way. ANZASM does publish de-identified cases, so it can't identify a hospital, can't identify an individual, can't identify a practitioner. There is to be no identifying information in the material that is actually published, and you're protected by legal process if anyone tries to seek it. There is also the state-based, which is the next slide, thanks David, the state-based schemes which operate in conjunction. It is an overlap and to some extent a duplication. So we know in South Australia there's a similar scheme operating and we're registered under that. There's a similar scheme in Western Australia and Victoria, and we're registered for those states as well. In Victoria, in more recent times, government and the health department in particular wanted to be more involved and wanted to know more about their hospitals, and was very interested in the information that we held through the Victorian ASM scheme. So they've set up a Victorian Perioperative Consultative Committee, which is led by a surgeon, a former president of the college, and it is similarly now registered under ANZASM, as well as the Victorian legislative provisions, which enables some sharing of information between the Audit of Surgical Mortality and the Victorian Consultative Committee, so that they can analyse, particularly for hospitals. They want to get to hospital data and see which hospitals are safer or performing better than others, which is the primary reason. It covers both surgery and anaesthesia. But again, the information, identifying information obtained, whether it's through the Perioperative Consultative Committee or through ANZASM, cannot be legally disclosed. So there's no identifying information that escapes, but we operate within the same bubble, as it were. And in Western Australia, there's a more limited sharing of information, which is the URN identifier, where if provided, then in Western Australia, we will confirm that the deaths that they relate to have undergone a quality review. So all the department there wanted to know was where there was a particular death that it had actually been reviewed through the ASM process in Western Australia. And when they provide us with the URN, we provide a confirmation as to whether it has been reviewed or not, and that's all they needed to know. There is a proposal which we're currently developing, which is for the situations, not common, but some is happening, where a patient has been in two hospitals and may have been handled by two surgeons, largely forming part of the same event for the patient. But in order to be able to put those two together, we seek the consent of the two hospitals and the two surgeons to be able to share the information, and we still de-identify as much as we can, although it may be obvious to each of the surgeons who we're talking about. But again, the information does not go any further than that. It can't be used by the hospitals, and they won't get any identifying information. Only the two surgeons will have access to the same information, and both surgeons will therefore get a shared outcome document that identifies the issues that may have been affecting the patient. Things that went well, things that didn't go so well, will be identified in the information that are provided to the two surgeons, but still under the protection of ASM and still on the basis that identifying information can't be provided. So that's being developed at the moment. I'm sure that there'll be more material about that as that is developed further. On the next slide, just a reminder that we also have privacy legislation. So patients will sign a privacy statement when they come into the hospital. So that does allow the use and release of their information, and particularly the release of their information to ANZASM. So it's one of the ways that we ensure that patients are participating in the program and not objecting to participation in the program because it's built into privacy statements. And for the purposes of research, again, we set it up as non-identifying where consent is not practical, or if we need identifying information, then we'll have a patient consent form. And at the end of the day, it's all subject to ethics approval, usually by the hospital involved, sometimes by a state ethics committee. But it is a way to get access to patient information for the purposes of ASM where needed, or for hospital M&M committees where necessary. So that sort of privacy regime is also utilised by us to some extent to get additional information under those grounds. But once we've got identifying information, it's very tightly held, and we have the statutory barrier to prevent any of that information being provided. In fact, we're prevented from providing it, but also to object to any subpoena or legal process that other parties, who some may have a legitimate interest, some may have a more pure interest, some may have a legal liability type interest, but at the end of the day, they can't access the information. And I think that's the reassurance that ANZASM gives to all surgeons who participate. So that's a legal lecture in a nutshell. Thanks, David.
Thank you. We'll have some questions at the end. So our final presenter tonight is Dr. Michael Cusack. Michael is the Chief Medical Officer of SA Health. As part of that role, he does serve on our SAASM steering committee. He is a key stakeholder in this perioperative space, and tonight he's going to discuss SA Health's wish list for data and feedback. So thank you, Michael.
Thank you very much. And like others, I would like to begin by I'll just start my slideshow. Yeah, like others, I would like to begin by acknowledging the traditional custodians of the land that we meet today, and pay respect to elders past, present and emerging. So in my wish list, in a way, for this for a clinical quality registry is probably quite short and limited. So in a way, this talk is going to be fairly brief, I guess, which should hopefully allow time for questions. But I guess in preparing for this, I'd sort of given thought to where I'd kind of come mentally in terms of registries, where I'd come from. And I guess you can tell by my accent, I hail from the UK, and before coming to Australia in 2017, I'd very much observed the emergence of surgical registries in the UK and the direction that they had taken over time. Probably all of us on the call will be aware of the Bristol heart inquiry following a scandal in paediatric heart surgery in Bristol. And as a consequence of that, over about the next 10 to 15 years, there was firstly the cardiac surgical audit became far more formalized, but really with a view to progression into publication, public publication of the audit results, and then named surgical publication of the audit data. That then moved further forward into other specialties. I think vascular came next, and my own specialty, sort of cardiology, came a few years later. And by the end of this process, there was something like 23, 25 surgical specialties, or specialties in general, which had named operator or named surgical data in the public space. Now, the data that went into the public space was very brief, and when you look up a particular surgeon, wouldn't really give you much of a flavour for how they operate and the kind of outcomes that they achieve. But what it did drive, and what I observed as it evolved in cardiac surgery, was absolute fastidious approach to the quality of the data, to the inputs, and to the degree of resourcing, which is something I'll just come to over the next slide or two, which is I'm involved in the National Cardiac Registry, which I thought would probably operate in a similar way to that I'd seen in the UK. But from what I've seen just over the last year or two being involved with it on the board of it, and latterly as the treasurer, is how difficult funding has been to come by, and to just keep the registry running and to keep the states involved. This can be a real challenge. And I think another comment I would make just before going through the slides is that there's something like 120 registries or so, 120 or so registries that are recognised in Australia, and these all have different inputs, different outputs. Some operate nationally, some operate on a state basis, some on a sub-state basis, and so there's real complexity to this particular space. But I think we'd probably all agree that having real consistency in terms of how a registry runs, having it well resourced and so forth, are probably kind of key requirements to ensure a high quality clinical quality registry. So just then, by way of intro, and I think this all feels fairly straightforward, but I guess in terms of the objectives and the scope of the registry, it clearly needs to have really well-defined primary and secondary outcomes. What's it for? And I think that needs to be agreed up front. And I think if it just starts to evolve in an ad hoc way with data points being added as the registry evolves and as people go along, I think that can give rise to real problems down the line. And speaking from a state health department, when it comes to really difficult funding decisions around these, I think that could be a challenge for the state to consider, well, if it's evolved in a kind of ad hoc way in that way, and we are left with what can we fund? Is it A or B? It may be that the more organised registry would be the one that would be more favourably looked upon. And I think these other points that I've just made on this slide sort of go along with that in terms of clear inclusion and exclusion criteria, and also I think consistent data collection across participating sites. And for a national registry, I think that is particularly key in a country the size of Australia, that you are ultimately going to be comparing apples with apples, and that different sites ideally have access to similar levels of resourcing, have different levels of kind of whether there is an audit person who actually has oversight of the audit in a particular institution and can assure the quality of the data, go back to surgeons subsequently and say, look, I just want to check this with you. Is this correct? Did this patient have heparin in advance, or were they ASO4, or whatever was the thing, just to be absolutely sure that the data is of quality when it's going into the registry. So having standardized data elements and agreed definitions right across the piece so that everybody understands what it is they're inputting and what they're being asked to do, I think that you would hope in establishing the registry that it would have comprehensive data points, because I think going back later and starting to kind of add bits and pieces to the registry can be very difficult, particularly when you've got a large number of separate stakeholders who you need to kind of get over the line in order to make your update your registry. From my experience at the National Cardiac Registry, I think when you've got multi-states and territories all with a particular view, different levels of funding in between them as well, doing subsequent changes can be really difficult. And I think to ease data entry, particularly if it's surgeons who are going to be entering their own data, I think that this needs to be made as user-friendly and as straightforward as possible. What we're looking at is how EMR extraction can occur, so that something like maybe 50, 60, 70% of data points can actually be lifted directly out of the EMR. And you would hope that in a future state, more of them than that even could be taken directly from the EMR into the audit. And as well, coming back, and I'm sorry to come back to cost again, but coming back to cost, we would want to reach a position where you measure once and use often, so that if we're supporting 20 or 30 audits, and they're each collecting the similar demographic data, similar hospital stay data, and so forth, of patients, can this all just be extracted at once rather than input clerks are having to kind of do this, or individual surgeons indeed doing this themselves over and over, which is clearly not a good use of people's time. So my wishes, I guess, for participating sites would be that they have access to their data on a timely and regular basis. I would think a reasonable timescale would be 3 monthly, but I guess I could foresee that 6 monthly and even annually could be kind of forced upon the audit, just in terms of how much resource the audit has to do this work. I think it does come back to, and Victoria are undertaking a review of the audits that they support right now. And I think, speaking to their chief medical officer, who is intimately involved in the process, he was advising he's been really kind of challenged by the health department to show value. And, his initial arguments would have been, well, clearly clinical quality registries are of value, look what they do. But the response of his health department, as I understand it, has been, yes, well, we understand that. But, as David said at the outset, we can identify that more older, frailer, multi-comorbid patients presenting in extremis, or certainly as an emergency, are more likely to have adverse outcomes than patients who are not in those categories. So what new information is coming through in these audits, and where can the audit next add value? And I think that's going to be a challenge for quite a few audits, and I would say SAASM included. Clearly, as well, there is a need for good data analysis and reporting, and I think risk adjustment and well recognised and accepted risk adjustment models, I think, are key, because again, different hospitals, different clinicians will treat different populations, and it could well be that different surgeons in the same department may well take on different cases or different case mix. And I think in order to make sense of what the audit is saying, I think it's sort of necessary to have excellent risk adjustment. In the absence of it, I think you end up with very wide error bars, 3 standard deviations from the mean to start to flag that there is an issue perhaps, and to try and pull more subtle detail out of the audit. I think without risk adjustment, that just gets lost in the noise. So I think where risk adjustment models exist, that should be part and parcel of the audit. And I think for the participating site, as surgeons, I'm sure you would want to be well collaborated with and engaged with by the audit and auditors, and have trust in it and confidence in it. And equally, you're getting back out of the audit data that is useful and actionable for you in your department, and as well timely, so that if something is coming back to you 18 months later, that may, things may well have moved on, and it may become a challenge to start to shift the dial on certain things when you're arguing about something, or you're making the case for something that happened, over a year ago. Now, wishes from the health department, and I suppose this better reflects than my own kind of personal wish list, is to receive regular communication from whichever registry, in whichever form the registry feels appropriate. And it may well be that the data that the audit would be sharing with specific sites or specific individuals within sites would not be appropriate to be sharing with the health department, but a kind of an added together, or kind of an oversight of a particular site or a specialty within a site, I think from a health department perspective would be incredibly useful. And I would say that at the moment is quite patchy across audits. So it either patchy in terms of timeliness, or we just don't see it at all. And I think, as well as the communication, I think that having some narrative with it, or tools for data interpretation, data visualization, it may well be that the data is coming to people that are not necessarily that familiar with what they're looking at here, or how to interrogate it. And I think to make good sense of it and good policy decisions on the basis of the data, and where to best put sort of support and resources, I think you want people to be able to kind of access or have the data in as accessible way as possible. I think ideally, just building on the points around how we assess risk in the data, I think we'd want to be able to benchmark, make comparisons with national and international standards. And, there's, I suppose, and I may well get pushback in the questions here, but I guess there's always a sense from a health department perspective of wanting to be able to kind of compare unit with unit with unit. Not in a negative way, but I think you'd want to be able to make assessments. Firstly, are your units safe? Are they providing high quality, good outcome surgical care to consumers that are using them? And I think where we have national comparators, obviously we should use them, but in the absence of those, or even with them, we should have international comparators also. I think increasingly we'd like to see patient reported outcomes, and particularly where mortality is not necessarily the key outcome. And obviously in your early slide, David, you put up around orthopedics, where clearly fracture neck of femur mortality is a key outcome, but there's a whole raft of other surgical procedures there, and in ENT likewise, where that may not be so. And yet I think having an understanding of functional status as it pertains to quality, I think would be very helpful, particularly again from a health department's view around making long-term making policy. And I think long-term patient tracking and follow-up again would be great. And then this is my final slide. In terms of other considerations, we obviously have a lot of data. I think in SA Health we talk about the data lake as opposed to sort of data farms and servers and so forth. There's huge amounts of data, and I think it would be desirable to be able to include audit or registry data together with that to draw other kind of meaning from it. I think this takes us into the realm of artificial intelligence or machine learning, but using algorithms to kind of pull information out of the data that may not have otherwise been immediately visible, accepting that that might not well have been the intention of the registry in the first place. But I think once the data has been collected, going back to that measure once, use often, I think that we would be keen to try and use audit data along with other health information systems, accepting that clearly the privacy and legal elements need to be observed. And this goes to the point as well about data linkage with other relevant databases and what other information can be pulled, or what other insights can be pulled from the data that we've collected. Followed on from there was, as it said on the slides, around input to surgical best practice, the use of the registry and registry data to input into the development of what is considered to be surgical best practice and to guideline development. And clearly, I guess, from a department perspective, we would really hope that, and I think would see it as a marker of a quality audit or registry, that it provides the tools or the input for quality improvement activities. That felt like a statement of the obvious, but I felt I should state it anyway.
Okay, thank you. Thank you very much. So that brings us to the end of our presentations. I'd like very much to, I'm sure our speakers would be happy to take some questions. If people would like to raise their hand and ask a question or give some feedback, we're more than happy for that. Sam, I'll get you to keep an eye out for the...
There is just one question in the chat from Luke Sanders, who has asked, what about including cardiology proceduralists?
Perhaps I might take that. From our point of view, we would really like to have, as I mentioned in my presentation, the significant input from interventional cardiology, interventional radiology, and emerging as gastroenterology. So we would be very keen to have that, but the Michael, and I'm sure Michael Cusack would be keen to have any procedural work going on with patients, but Michael Gorton might tell us how it works if we were to involve other specialties or other colleges even.
Yes, it's possible, and with some of the other programs that we've certainly had registered, it can be joint or with the participation of other colleges or other organisations. In Victoria, the Victorian Council and ANZASM are linked, but that required some fairly complex arrangements. but we can still receive information through other programs within the ASM program as it's currently set up, and it will still be protected. So we could have participation. We could have other physicians or clinicians, non-surgeons, contributing views which come into ASM and therefore would still be protected information. So it's possible to have that sort of form of participation if it's a more structural participation. So they want to have a joint program covering two, then we'd have to go back and change the statutory protection to cover both.
Yep. So we've got a couple of questions coming in on the chat. I think one from Michael E, which I think probably for Michael Gorton. Has any surgeon been sued after publication of SAASM despite qualified privilege? Have we kept our slate clean?
No surgeon has been sued on the basis of any information held by ASM or in relation to participation or reports within ASM. Okay. Now, of course, they can access hospital data and hospital information and draw their own conclusions or get a second opinion, but that's entirely different from the sort of material that we get within the ASM program. So remembering that the ASM program is a direct contribution by the surgeon. So the surgeon is providing their information, their data, their perspective. There may well still be stuff in the patient record which can be accessible, but this is where the surgeon will probably express views more frankly, knowing that they're protected by statutory confidentiality.
And just following on from that, Michael, our assessors that write reports for us, if those comments don't go over well, can they be defamatory?
No. They're professional views given within the context of a scheme which is protected, but just as professional views, I'm not aware of any surgeon having been sued or even threatened under those circumstances.
Thank you. Got another question from Aruna Kartik, who has asked about identified outliers and considerations for outlier management. I guess I might take this one. I think that again, it's an exceptional or almost unknown process for us to see an outlier surgeon. The issues that would probably lead to outlier management, and RACS does have a policy for that, which would there would be a process, and I think again it would be performance that was documented by hospitals or LHNs that would be involved in that. I think probably there's more local issues that you would usually lead that than the data that we would have in the audit. It's very, very difficult to, with our use of words like consideration, to see someone undergoing a formal outlier management program.
And David, that was certainly one of the issues that arose when we set up the ASM scheme in the first place. It's not a scheme that's intended to be punitive. It's not a scheme that's intended to identify outliers to be dealt with. We can certainly talk to surgeons who may have appeared as outliers and let them know they've appeared as outliers, but we can't reveal that sort of identifying information to any other process. So it's not intended to be a punitive scheme, and that's why we have such a high rate of participation by surgeons as a consequence, and we get very rich data.
And I think along the same lines, the individual surgeons report, which is essentially confidential to individual surgeons, would basically identify to that surgeon that they were an outlier, or that they're given feedback data about other people in their specialty and the number of CMIs accumulating.
I was just thinking, David, as well, just with that question, that that SAASM would just look at single cases undertaken by a surgeon where the patient had died, rather than the full extent of a surgeon's practice, which I guess, I suppose, if the performance in that one case appeared to fall some distance below what is deemed acceptable, then as you say, then one, either the surgeon could consider reviewing themselves their practice further. But if you're not auditing a whole, if you're not registering a whole of a surgeon's practice in a particular procedure, I think it would be very difficult to point to them as an outlier. Would I be right?
Yeah, I think so. And I think the other thing too, if a practitioner has is fallen below the level at which there would be management, I think that you would, in most situations, it's complications and behavior, and there's if we were waiting for deaths, I think we would be missing the boat. And most people that would be under an outlier management are probably at that level, and the deaths, we would want to not just count the deaths, for example. And I think the other thing that comes out very much in the audit is the nature of surgical practice as a broad thing. So within our state, if we look at trauma surgeons and neurosurgeons, they are, they will be participating in the audit regularly. So it's very easy to say, not to count, whereas other specialties that deal with elective work, ophthalmology, they're never going to fill in a form. So we have to be very careful, particularly in people, in the role that they're in and the work that we're asking them to do. Any other comments or questions?
It looks like we just have one in the Q&A from Shalvin Prasad that just says, how does SAASM ensure that first line and second line assessors have adequate subspecialist expertise or experience to carry out a subspecialty mortality case?
Essentially the answer to that question is that at a first line assessment level, there's not much differentiation of subspecialist mortality, subspecialist knowledge, but what would typically happen is that a first line assessor would say this is a complex case from this jurisdictional specialty, and we would recommend that it go to a second line assessment with a practitioner who has expertise in that area, and we then can direct and choose usually the second line assessor rather than the first line assessor. A couple of things coming up. Luke Sanders made a comment, post-mortem reports are notoriously difficult to obtain in WA. I think you make a really good point. The issue of post-mortem reports, which effectively is usually a coroner's post-mortem, is really something that would help us a great deal, but it is very difficult, and of course not all patients do receive a coroner's autopsy. There are case note reviews and coronial CT scans and things, but that's something where often quite reasonably it's been suggested in SAASM that we would wait until that's available, but that's a painfully slow process for us, and if we wait for the coroner to release that data, it can be quite a delay. But that's been a problem not just in the surgical audit, but the low rate of postmortems generally means that things like death certificates and causes of death across all jurisdictions have deteriorated quite a lot. Michael Cusack, do you have any comment about what post-mortems and?
I suppose an observation I'd make is the time, as you say, the time from the event to the post-mortem could be years.
Yeah.
And I mean, in a way, it does seem remarkable that particularly if there's going to be a significant finding, that we find the finding years later. I mean, you would hope that the system had itself identified the particular issue and had moved on the issue before time. But yeah, I think this is, I feel, at a personal level, this does really feel to be an issue, but not one that from the State Health Department we would have much leverage in.
Yep. So there's a comment by a question from Mark Edwards, says, what action or process does SAASM have to deal with a surgeon who's clearly well below the accepted standard? Well, I guess we have from my point of view, I guess we have the same requirements as any specialist in APRA of when we become aware of someone falling below that standard. Michael Gorton, what responsibilities do we have to deal with that?
Of APRA is also subsumed within that. So no, we don't even report it to APRA. We can't. So we're prevented from any punitive measure on the basis of the Commonwealth legislation. And again, that's the reason for ASM is to get information and to improve the quality and performance of surgeons as a whole. And what we give up is the risk of identification of those of substandard performance or even riskier sorts of things than that. So no, we can't even report it to APRA. And I say that as a former chair of APRA, where that very issue has been raised.
I mean, I think also the way in which, again, coming back to the way in which we identify a clinical management issue, I think we would really not be thinking about it in terms of people falling below effective standards. We're simply identifying where there may have been an area for improvement. So this is a different process.
Yeah.
All right. Well, I might bring us to the end of our evening webinar tonight. I really do want to thank our speakers, Michael Gorton and Michael Cusack, for their participations and their contributions and their time that they've allocated to this. I'm really grateful. I want to thank the SAASM staff, Nathan, Sam and Emily Rose, for their efforts in bringing the webinar together. And finally, can I thank everyone for taking the time to participate tonight. We will be having another webinar in February for SAASM. And I'd like to wish everybody have a great evening and the rest of your week goes well. Thank you, everyone.